Okay, diagnostic measures to diagnose the reasons and diagnose diabetic ketoacidosis would be we would get complete blood count, which will find information about infection, CMP, complete metabolic panel. We will get some information about liver function and kidney, arterial blood gases, our pH, our acidosis, urinalysis. We'll get also infection and the status of the diabetic ketoacidosis process. Ketones, well, that's just to get them. Osmolarity, we'll get that in 12-lead EKG to monitor for those arrhythmias. Yes. So serum glucose, usually in diabetic ketoacidosis, it is 350, and of course it can be above, but it's around 250 because they're still able to pee off some of the sugar. In hyperosmolar hyperglycemic state, they will have 600 glucose, serum glucose. pH, the pH in diabetic ketoacidosis is low, below 7.3, which is they are acidic. Their bicarbonate will be below 18, and the normal are 22 to 26. So that will be below, and urine serum ketones will be high, will be present, super high serum ketones. In hyperosmolar hyperglycemic state, they will be very low. Anion gap, it's where we subtract free anions from cations, will be above 12. Because there's such a big difference, because there's so many of the cations. They're high. And serum osmolarity variable, but in hyperglycemic hyperosmolar state, it would be above 320. So why do we have so earlier I talked about carbon dioxide that is being produced through the conversion of hydrogen and bicarbonate through the carbonic acid into carbon dioxide, and this is basically the formula to the process that occurs. We have too many hydrogens, a little bit, quite decent amount from 22 to 26 units of bicarbonate, and hydrogens and bicarbonate combine, they become carbonic acid. Carbonic acid is further being converted into water and carbon dioxide. Water is pinged out, carbon dioxide is being breathed out. So this is some of the things we would use to diagnose diabetic ketoacidosis. Now, management. So we want to establish circulation, establish IV accesses. We'll get the blood for analysis to get the potassium levels. We will administer fluids, most like a normal saline and insulin. Insulin is right here. We'll monitor the ABGs to see how we're doing on our pH and our bicarbonate. We will also get a full blood count and EUC, and this will give us information about infection, electrolyte abnormalities. Urinalysis will check for glucose, ketones in the urines, and any infectious particles. We'll get the electrocardiogram to monitor for arrhythmias, and depending on the person's laboratory results for CMP, we will be regulating our fluids, saline, and we might add dextrose, depending on their glucose levels. Should be somewhere above 200, somewhere around 250, and we'll monitor sodium and their potassium. So based on that, we'll give all these things. We don't want to get them too low on either sodium or potassium or glucose. Overcorrect these things. We don't want that. We'll monitor urine output to make sure they're still peeing out. So here's the 3 components that we will administer to them. So first one is normal saline. We'll start about 2 liters of normal saline per hour, and then in about an hour we check their sodium and glucose. And if the sodium is low, if it's still low, if it is low, we will continue with 250. We will change it to 250 cc's per hour, and then recheck in an hour. Also, if the sodium is normal or it is higher than what we need, we will switch them to half normal saline, 0.4 normal saline. And if we have too much glucose, too little of glucose, we will change it to maybe 250 cc's of normal saline or half normal saline, and add some dextrose. Into it. Also, we will give them insulin. Insulin is measured as 0.1 unit per kilogram IV push. So first we'll give them the bolus. So how much is that? That's not too much for a 70 kilogram person. So if you multiply that, you will get 7 units of regular insulin. And later on you will titrate all these 7 units per hour. If you see that their sugar dropped below 200, then you change the formula to 0.05, half of that units per kilogram per hour, and then recheck in an hour. And eventually we want their labs to be within normal limits, and also their symptoms plus signs to resolve. Also potassium, the one that leads to arrhythmias, and ileus. So what about that? We'll check their BMP results. If their potassium is above is below 4.5 microequivalents per liter, we will add some potassium into their to their infusions, and it's going to be 20 to 40 microequivalents per liter. And if their potassium is even lower than 3.3, then we will add the 20 to 40 microequivalents per liter of potassium, and we'll also stop the insulin, because insulin helps the potassium get into the cells. So we need to monitor insulin too for potassium. Alright, and we will stabilize their labs, we'll stabilize their symptoms and signs. They will resolve, and the patient will be discharged home. And we'll provide some education to the patient, of course. Alright, thank you. Have a good day.